Recording before I forget. And Sophie, if I remember correctly, you do have some polls.
Yes, I have
Okay.
some polls.
I'll pay attention for that.
Thanks.
Awesome. Okay. John, if you're okay with it, I think we should get started. Welcome everyone to Academic Half Day. A special welcome to any interns that have not yet been to Academic Half Day. It's our Thursday morning kind of outpatient didactic series, but we learn about more things than just outpatient medicine. I'm really excited about today because we have 3 different residents who are in the clinician educator pathway giving us talks today. So these are almost always fantastic. And we are starting out with Sophie Padelford, who is teaching us about dying.
Yeah. Hi, everyone. I'm Sophie. As Nikki said, I'm one of the Clin Ed R3s. My nice, cheerful topic for 9 a.m. on this Thursday morning is an introduction to dying, kind of hopefully appropriately timed for this spooky season as we get close to Halloween. Oops. All right. So my learning objectives, I'm hoping to just make everyone feel a little bit more comfortable working with patients who are actively dying and feeling more comfortable helping patients' families navigate the dying process. My main learning objectives are going to be 1, I'm going to explain and summarize the physical changes and approximate timeline of active dying. So this is sort of the days prior to death, and hopefully make you feel empowered to share that timeline with patients and families and sort of demystify the dying process a bit. My second learning objective is I'm going to explain patient and family concerns about loved ones dying and how to mitigate those fears and concerns, particularly help families with sort of the emotional aspect of letting go of their loved ones. And 3, I'm going to go briefly through sort of the logistical, practical steps that need to be taken after a patient dies, particularly in the hospital. I think this is something that probably most of the R2s and R3s have had the chance to practice at this point, but particularly for the interns, if you happen to patient die yet, I know that was something that I was really worried and stressed about as an intern. I think it's a really common fear. And I want to make everyone feel empowered that they are going to take great care of their patients, their families, even after that person has died. All right, so I'm going to start off, as I said, by going through the timeline of active dying. Just a little side note, all of these photos are from Wilma Jensen, who's a photographer who did a really cool project on patients and families during the hospice process. So if you like them, I encourage you to Google them because there are a lot more really cool ones where these came from. All right, so most of the emphasis of this section of my talk is going to be on sort of the days immediately prior to death. But before jumping into that, I thought it's important to sort of frame these last few days of life in the context of the months or years pattern of decline that patients go through, because I think that can really change how dying is perceived by the patient and by the families. So this was a really interesting graph that I took from a review article that was talking essentially about the patterns of decline and approach towards death that patients go through. And I think we can probably all think of patients that we've known that have fit these different patterns. So the first pattern on top is sort of someone who's mostly coping really well, probably is mostly an outpatient, probably managing most of their symptoms reasonably well, and then has a pretty rapid decline and death. And this is actually best described in the cancer population. Maybe for the R1s who have done HEMONC or the R2s and R3s that have done HEMONC in the past, we might remember these sorts of patients. These are the patients who are admitted kind of once to the HEMONC service with some complication of their usually solid malignancy, and then die relatively quickly over a short period of time. The reason I think it's important to think about the pattern is, as you can imagine, this pattern has pros and cons for the patient and family. You know, on the one hand, they're spared sort of the repetitive trauma of being admitted to the hospital over and over again, kind of close brushes with death. On the other hand, the end can feel really fast and kind of unexpected for patients and families. And these might be the sorts of folks that we're having goals of care conversations with, and the patients or families feel like they've never really thought through the details of how they want to approach the end of life. This second pattern, I feel like, was really familiar to me from my month on H cards. You know, even in the context of like 1 month on H cards, I feel like you see people who you admit over and over again with these like really severe symptomatic exacerbations of an underlying medical condition. So this is sort of mostly heart and lung failure. These patients have sort of a slower decline punctuated by these really impressive exacerbations or increase in symptom burden, which may coincide with a hospitalization or a pretty significant increased need for care. And again, to me, this pattern really reminded me of the patients that I taken care of AHD cards. You might also think about this pattern for maybe some of our patients that we're admitting with recurrent COPD exacerbations, where like over time, the patient's not getting better. Their like exercise tolerance never gets back to where it was. At some point, they stop working, they never fully recover. And then they have these really severe symptomatic exacerbations. I think similarly, we can think about how this pattern would be experienced by the patient and family. In this situation, this person's probably very frustrated or could be very frustrated. They probably keep being admitted to the hospital or keep needing to have intensive medical care. They might not have actually had the chance to think about what it'd be like to be close to death with these sort of big exacerbations with increased severity of symptoms. But the actual death itself also might come as a surprise because, as you can see from this graph, they've had the chance to recover and maybe return to community living or return to a skilled nursing facility. And when they finally do pass, it may feel relatively unexpected, depending on how often they've had these exacerbations and been able to recover. And then finally, this last pattern, sort of frailty, dementia. This is someone who's like really not very well for a super duper long period of time. They're slowly dwindling over time, but they really hang on for a long time. To me, I felt like this pattern was most consistent with patients I've seen on like geriatrics, where you're like, man, this person's still really here and like they're still hanging on, but like they're sure not doing well. And they've been here for 2 months and they're like not out of bed. And I can't believe that we're thinking about they might be able to discharge. And the reason I just bring all these up is, again, I'm going to mostly focus on the last few days prior to death, but I think thinking about, what has been the patient's past medical history and how have they experienced sort of their declining health, I think is important. All right, and then briefly just to review some physiological changes in the days prior to death. So patients generally have mental status changes. So this can be either decreased level of consciousness, which is more common, or heightened agitation, kind of hyperactive delirium. We see an inability to close the eyes in the days prior to death, and this can be really distressing to patients or more families. This is really due to the loss of retroorbital fat pads behind the eyes as the patient starts getting thinner and losing subcutaneous fat. We see decreased urine output and we see decreased urine output. We see a decreased appetite. So patients generally voluntarily first stop eating and then stop drinking due to decreased desire to do so. Loss of a gag reflex. I didn't put this on here, but also loss of strength of the swallowing muscles. So sort of increased risk for aspiration in the days prior to death. Decreased blood pressure and increased skin breakdown, including this can put people at risk for sacral ulcers in the days prior to death. Obviously, an ulcer wouldn't develop in days, but sort of in general, the skin starts to break down. Okay, so this is the first question. So Nikki, I'd be grateful if you could put up a poll. I will give everyone about 1.5 minutes and then we'll discuss it all together.
Sophie, can you see the poll results?
I can't. I was
Okay.
going to give people about another 30 seconds.
Yeah, no worries. I just wanted to, maybe like half have responded. So
Okay, maybe take another 30 seconds. If you don't answer, that's the same as hanging up on the daughter. So very gauche.
okay, responses are narrowing, so I'll end the poll.
Okay, thanks. Okay, great. Thank you everyone for not hanging up on the daughter and committing. Appreciate it. So it looks like we have got a good spread. So I see some people thinking A, so prognosis is hours to days, can't make any narrower guess. Some people recommending that the daughter does come in to see her mom. Some people saying, I think it's okay to wait another day. And it looks like no one wants to consult palliative care, which is going to be one of my goals, is to convince you that I don't think you need to consult palliative care in this situation, but always, of course, reasonable if you're overwhelmed. All right, so the correct answer is you should probably recommend that the daughter comes in to see her mom, given sort of her goal of being able to come in and see her before she dies. And I'm going to share with you some of the specific information about the timeline that allows you to predict how close the patient is to death. And, you can't say 100% the mom is going to pass today, but I think it's really very likely. So I think this is the most appropriate recommendation to make to the daughter. All right, so here's a timeline of active dying, basically where I put up a bunch of physical signs, so less symptoms, but physical signs you could see on exam and kind of how soon they happen prior to the person dying. And there are a lot more of these. I took 5 of these from a paper from Dr. Hollenbach, who's a palliative care doctor down at Stanford. And these are sort of like the ones people talk to the most. And then I added in 2 more that I thought were helpful. So starting on the left, so these are the things that are the furthest away from death in terms of average time of onset. We have RAS less than or equal to -2. So from our ICU rotation, we probably remember this is someone who's like very deeply sedated, kind of unresponsive, not really awake answering questions. At 60 hours, so between 2 to 3 days, we see drooping of nasolabial folds. So if you've gotten to know your patient well and you kind of know their face, you might see that those characteristic creases around the mouth are now flattening. At about a day prior to death, and here we actually have some standard deviation data, so you can see the standard deviation is large, but at about a day prior to death, we get a death rattle, which I'll share with you a clip of what that sounds like. But basically, it's a collection of some secretions in the upper airway that produces sort of this characteristic abnormal breathing sound that patients or families might notice. Usually within a day prior to death, we see mandibular breathing. So this is sort of the jaw moving in and out as the patient breathes. And this usually happens hours prior to death, although the standard deviation is 18 hours. So it is a little wild. It is a little wide. Cyanosis modeling usually is like, which was something our patient had, on average is within 1 hour prior to death. So that was part of the reason I think you ought to recommend that the daughter come in. Although, as I said, there is a wide standard deviation. So it's possible she'll come in and her mom won't pass. And then the lack of a radial pulse is sort of the best described sign that like the patient is like imminently about to die. So this means really they're like not circulating their blood well. They have decreased peripheral perfusion. And this is usually, again, at about an hour prior to death, and the standard deviation is much narrower. So our patient, Betsy, had these 2 signs on the right, which together, I think, in my opinion, that can make you like reasonably confident that she's probably going to die sometime during the day, and you ought to recommend that the daughter comes in and visits her mom. All right. Oops. So here's an example of drooping of the nasolabial folds. This was a really interesting study done in cancer patients where they were looking at a number of different physical signs. I thought this was just interesting. And basically, this is just the face is losing muscular tone. So you get this sort of bilateral drooping. And again, you might have to know the patient a little bit to be able to recognize this. I would like to play for you the death rattle. I'm going to try to play this YouTube video that's just sound. It's only like 10 seconds long, but I want to share with you. So if it goes horribly and no one can hear it, we'll just move on. It's fine. I'm going to start playing it and then I'm going to go forward. I don't know if people could hear that. Can people hear that? No. Okay. I'm sorry.
We could hear the beginning, interestingly, but not once you moved it forward.
Well, I'm not going to imitate the death rattle because I think that's disrespectful, but I would encourage everybody. It's only like 10 seconds long. just, you can even look it up on YouTube while I'm chatting if you get bored at some point. But basically it's like a really junky, deep, rattling respiratory sound that's with inspiration and with expiration. Looks like maybe Dr. Cho had a suggestion.
No, I was gonna say we can look for this link while you're going on.
Yes, everyone should feel empowered to look it on as I keep going because I wanted you to hear it.
Sometimes crackles are produced by the
Uh-oh.
accumulation of secretions in the airway.
Okay, so there were some signs and symptoms. Now we're gonna do like a different question. Maybe if you finish this early, you can look up a death rattle. And Nikki, if you can launch the poll, and again, I'll give you about a minute and a half. Maybe about another 30 seconds, try to commit.
People are still trickling in. Things are slowing. So
We gotta get through dispo rounds. We got 15 more patients to talk about. All right. Thank you everyone for committing. So it looks like most people picked A. A few people picked B, and then a few people picked C. So A is the correct answer, and I'll go through why. But most people's inclination was correct. C, a little bit of a distractor. I see Joanna in the chat asking about like what inpatient hospice is. Don't explicitly address this in this talk. I was thinking about including some like disposition stuff, but I ended up not. But briefly, inpatient hospice is different from comfort measures only. It's a special sort of care that's reserved for people that are actively dying or close to death, but have needs that cannot be met with home hospice or SNF hospice. So these are like folks with say like a complicated pain management plan that's being constantly updated. Like someone who's not just on like morphine or like a drip, but someone who's on like a PCA that's being actively titrated.
Or another example that comes up on HEMONC is if someone needs high flow for comfort for air hunger or CPAP, you can't do that on home hospice. So really the only time that inpatient hospice was relevant to my residency experience was on HEMONC, for better or for worse.
Yeah, I'm sorry, I didn't fully review the criteria for this, but does anyone else have any other examples they want to share about eligibility for inpatient hospice? In my experience, it's very hard to get patients to qualify for inpatient hospice. So in general, it tends to like not be a great disposition option. All right, I'm gonna so yep, A was the correct answer. So this question, like I didn't give you as many of the physical signs that you can use to sort of judge whether Rolf is close to death or not. What I wanted to share was that in addition to using physical signs and symptoms, you can also use the patient's basic level of functioning and sort of engagement with their care to estimate prognosis. And again, I would never use like any one sign or symptom or any one measurement in a vacuum, but I think you can kind of triangulate all these things together and think about making it a best guess for prognosis. So this is called the palliative performance scale. It's used in a bunch of different contexts, but one of the contexts it's used in is in terms of estimating how close a patient is to end of life. And we see here that sort of a score, a numerical score on the left and a percentage. There's how much they're able to walk around, there's sort of how much activity they're doing, there's how much self-care they're able to do, how much eating and drinking they're doing, and how conscious they are. So for our patient, Ralph, he's at this 10% level where totally bedbound. We learned that he was drowsy. We learned that he'd stopped eating and drinking and was only getting oral care by the RN. So this puts him at this 10% level, which is the stage immediately prior to death. And this was from a really interesting, that same HEMONC study that I was showing you the picture that nasolabial folds from. Basically, they were looking at different factors and seeing how well they could predict how close patients were to death. And specifically, they were trying to look at which of these things indicate a 3-day mortality risk. So the patient dies within the next 3 days. And they, as I told you, there's like a bunch of different physical signs you can look at. I only shared 6, but there's more. They were basically saying, okay, the more physical signs someone has that correspond with approaching death, the more likely they are to die within the next 3 days, which makes sense. And then similarly, on the left, they were looking at palliative performance status. So how much stuff is the patient able to do? How alert are they? How much are they eating and drinking? And then tracking that likelihood with their likelihood of dying within the next 3 days. So we said Ralph was at 10%, so he's down here. So if we trace it up, we can see we're above 50%. So that by itself doesn't tell you like, oh yeah, he's definitely going to die in the next 3 days. But I think answer A is still accurate, where he's more likely than not. And if he were really our patient, we of course could go and see him and try to get a little more data in terms of making this disposition decision. Whoops, I think I skipped a slide. Okay, this was my like big take home for part 1. So the timeline for active dying is imprecise, but you can approximate it. So get close with physical signs and functional performance. And I would also argue that I think there's a lot of uncertainty in terms of estimating prognosis, but we probably owe it to patients and families to give our best estimate, kind of reflecting the uncertainty that we have, because that really does matter for family planning. Does anyone have any questions before we move on to the next part? Or comments? I'm down for comments. I see some good comments in the chat. Thank you, Gina. All right, I'm moving on. If anyone has any questions, they can feel free to put them in the chat. Oh wait, one more chat. I agree, Adrian. I think it is really uncomfortable. And I think it is, unlike telling a family the results of an imaging study or the results of a lab, like we're telling them something that has a lot of uncertainty. And I think it is important to reflect that uncertainty, but also like it makes a big difference if family is able to be there to say goodbye and kind of, I think we want to aim to have like a shared mental model with the family of like, this is how close we are to death. And like, this is how much time we have left. So we can really prioritize what's important to the patient and the family.
Can I say one thing, Sophie, too, that I wanted to highlight, which was, I think Lindsay said this, but how challenging the uncertainty of this process is for families. And that sometimes they just want someone to like give them a recommendation. And I think we're really trying hard in medicine to not be paternalistic, which is a good thing. But if someone is asking for your opinion or advice, it's also okay to offer a suggestion. And I think that is really, I found that really challenging as a resident where I was like, how am I qualified to be giving this recommendation? So that's why I think this talk is so good, Sophie.
Thank you. Yeah, thanks for that comment, Lindsay. I think you're right. It can be very, very overwhelming situation. People don't have a lot of practice with loved ones dying. They've never gone through this before. So even though we don't feel like we have that much expertise, they have even less expertise and the situation is higher stakes for them. All right, I'm gonna go on to part 2, which is helping patients and families cope. And a lot of the emphasis in this section is going to be on sort of the emotional aspect of things and less so on like specific medications. I actually feel like as you go through residency, you get more comfortable with like the CMO type meds and those sorts of things. All right, sorry, I really like questions. We're gonna start off with another question. So back to Maggie. We told her, Maggie and Betsy, we told Maggie to come in to see Betsy. Let's take about 1.5 minutes to work on this question. Marissa, do you have a question or comment? Okay, take about 30 more seconds. Try to commit to an answer. All right, I think we're at a good place, Nikki. Great. So most people pick the answer that I would say is the preferred answer, which is we can try a medication or some oral suctioning, but breathing pattern is not thought to be uncomfortable. Kind of looks like the other answer people picked was B. So thinking that this means the patient's likely to die in the next couple of hours and that they should focus on spending time together. I think the only bit of B that's incorrect is, as we looked at that timeline earlier, this doesn't actually indicate the patient's likely to die in the next few hours. It's sort of the next day or so. So I wouldn't want to mislead in terms of the timeline. Well, that's a little confusing because we did talk about the patients like likely to die over the course of the day today. So I get why people would have answered that. And I don't think it's inappropriate to recommend that the daughter focus on spending time with the mom. So reasonable answer, but I think the best answer is D. I'm glad no one picked C. Nothing that we would do to treat the death rattle is thought to prolong life. So we can treat it if it's really bothering the family, but it's not thought to be uncomfortable and it won't prolong life if we get rid of it. And I'm glad no one picked A. Hopefully everyone kind of remembers that deep suctioning, so like really getting in there and sucking all the goo out, pretty uncomfortable. Patients are usually coughing and spluttering and like don't love being deep suctioned. It's like really not very patient-centered to deep suction somebody to treat a death rattle, which we don't think is that very uncomfortable for patients. Okay, my just like big take-home point is like, there's a lot of weird stuff that happens when people are about to die. A lot of it the patient might not have experienced before, the family might not have experienced before. It's not all uncomfortable. So sort of being able to walk the family through what changes we sort of anticipate seeing, I think is important. So here are the most common symptoms preceding death. Probably not surprising to anyone. We see pain, we see shortness of breath, we see somnolence, or conversely, agitation, so kind of agitated delirium. Constipation is a really common one, and actually like a really big focus in the literature is avoiding and treating constipation in patients that are actively dying, because that's pretty dang uncomfortable and can really actually be really bothersome prior to death. And then nausea. And as I said, I'm not going to really go through like morphine dosing in this presentation, but just briefly to review, I think we're probably all pretty comfortable with the medications on here from like the CMO pathway, but pain, really the mainstay is usually opioids. For dyspnea, again, usually opioids. You can try a fan. I haven't had great luck personally in doing this. This is something that's talked about in the literature. I think it was also, you couldn't do it for a while because of infection control reasons. Well, at least when I was like an intern, but maybe we can use fans again. You can use oxygen, as Nikki was talking about, and thinking about like patients on HEMONC or on like high flow for comfort, particularly if they're hypoxemic. It's sort of less well established if it really helps with dyspnea if they're not hypoxemic, although obviously you can always try. For agitation, it feels a little like metal that we're still giving these like dying patients like Haldol or like risperidone, but these are actually the best studied for kind of agitated delirium. Of course, you always want to do your first pass sort of delirium screen and treatments, like thinking about if they're in pain or constipated or confused, etc., and treating agitation as you can. Constipation, kind of our standard medications with the additional thought that like we really should think about these selective gut opioid antagonists for folks who've been using a lot of opioids, since opioid-induced constipation is very common. And for nausea, kind of usual medications plus steroids, particularly for patients who have partial or complete small bowel obstruction, which can happen as a result of physiological changes kind of leading up to death, and cannabinoids. So either synthetic cannabinoids or more if you're out of the hospital, you could use, natural cannabinoids. Oops, gosh. No. All right. Well, hopefully people weren't paying close attention. Another question. Take about a minute. You got a little bit of a spoiler and we can discuss the answer. This is back to your second patient, Ralph, the one with the GI bleed.
Okay, things are slowing. Are you okay if I end the poll, Sophie?
Yeah. Yes. What did people say? Great. Vast majority of people picked what I think is the most appropriate answer, which is talking to the family about a lack of appetite, as we talked about earlier, sort of a natural part of approaching death. We really don't recommend intervening to try to change the patient's natural appetite. B and D, which were the other answers, and I'm glad some people committed and picked some other stuff. It's like B, I like get the spirit of this, and I wrote this and I was like, I wrote all these questions. I was like sympathetic to this, where it's like, you're trying to suggest like an alternative way for the family to feel like they're taking care of the patient and they're like nourishing him the days prior to death. The reason I would not do this is there are risks associated with eating. And I think specifically like trying to push these high calorie foods, high fat foods is pretty likely to cause some like nausea in this patient, which can be quite uncomfortable. So I think that's actually not a great answer unless the patient's like very interested in eating these things. And then D, again, I think this is like right spirit, where we're like trying to think about like, how are we taking care of this patient? How are we expressing like our love and like concern for this patient? We're thinking about like, oh, maybe we can like try to keep his kidneys like a little bit hydrated. But again, as we saw in that first slide, where that body with all the different arrows pointing to natural things that precede death, like decreased urine output, is just a result of decreased renal perfusion as your circulatory system stops working well. So in general, we will not help the kidneys by giving additional IV fluids, even when urine output is decreasing prior to death. Okay, and then just like some explicit notes on eating in the final days, because I think this can be quite a distressing aspect of the death process, dying process for families. So I think the headline is that lack of appetite is probably adaptive and protective for the patient. So it's probably actually helping them be more comfortable and live longer. Because specifically when people are getting close to death, their muscular tone decreases, as we saw in the decreased labial folds tone. Their cranial nerve reflexes decrease, like they usually lose their gag reflex. They often have decreased transit time in the gut. So like forcing someone to eat pushes them at both a very high risk of aspiration and at quite high risk of nausea. So if someone's like not hungry, you know, a family that's really worried about someone and trying to care for them might be like really pressing food on this person, and it might actually hasten their death, which obviously is regrettable for the patient and like very horrible for the family if they are forcing someone to eat and then the patient aspirates. That's obviously like a very bad way for the person to go. Fluid replacement is more controversial, and you can definitely find literature that's talking about the role of like IV fluids in preventing thirst and like the role of IV fluids. There's specifically some interesting stuff about like IV fluids to prevent like the death rattle, which kind of its own interesting circular thing where you're like, we don't think this thing is uncomfortable, and now we're giving fluids to try to like decrease this thing that we think is asymptomatic. So it seems weird to me, but like there is literature out here on this, but in general, the headline recommendation seems to be not to give fluids just because of decreased urine output or decreased oral intake, because there, as we all know, there are like risks associated with administering fluids. If you think about these like old, frail people who like aren't eating, they're going to have very low oncotic pressure in their blood. They're very likely to third space. One of the most common symptoms we see is dyspnea. They're like pretty likely to become more short of breath because we like give them a bunch of fluid when they develop pulmonary edema. And they also, as we talked about, are more likely to have skin breakdown. So they are pretty likely to become edematous and then more uncomfortable and have more skin breakdown. So yeah. Gina, that is like a great question. I do not know. I read a lot about like mental status changes prior to death, but it was like a really big topic. And I ended up feeling very underqualified to talk in more at more length about it because it was like really complicated. So the short answer is I don't know, and I don't understand the nuances of mental status changes when they talk about like euphoria or like the difficult road to death in the last few days. But great question. Okay, and this is from this palliative care doc I was alluding to earlier. This gentleman, this doctor down at Stanford, Dr. Hollenbeck. I really like this. This really resonated with me. It's something I read like a long time ago, and I've come back to it multiple times. Which basically, what this is a chart, and this is the patient who's the furthest away from death in the active dying process, but still actively dying, and this is the patient who's like the closest to death. And we think about the senses that the patient loses. What the family loses is the patient loses that particular sense, and then a coping strategy that we can offer. So as we've just been talking about, hunger tends to be the first thing that's lost. The family loses the ability to offer food, to feel like they're nurturing their loved one. And sort of the coping strategy that's suggested is offer other ways to nurture. So like what's another way that the family can show love, care, affection for their family member, if that's like sitting at their bedside, holding their hand, reading, a favorite book or poem, like playing a favorite song or musician for the family. Like what's an alternative way that we can help the family express taking care of their loved one? Thirst, similar. The family loses the ability to feel like they're caring for their loved one. In addition to all the things I just mentioned, you can also kind of coach the family on oral care and helping keep the mouth moist and the lips not chapped with chapstick to offer some alternative ways of caring for the family member. Next thing people tend to lose is the ability to speak. And that's a huge loss for the family. You know, a lot of folks are seeking closure in the days prior to death, and having the patient be able to speak and communicate is really important. And I think the only thing we can offer in return is that the family member, likely when they lose the ability to speak, initially can still hear. So that pathway of communication is now one way, but it's still open. Next thing patients lose tends to be vision. And again, family suffers tremendous loss from the loss of being able to be seen. But I think what we can offer is that the family member is likely initially when they lose vision still conscious and still maybe aware that their family is there, even if they can't see them, so can still appreciate their presence. Next thing that's lost is hearing. And again, this is huge because now the patient can't speak, the patient can't hear, the patient can't see. We've really lost most of the standard ways of communication that folks use in their lives. I think the thing that we can offer is that the sensation we think that's lost last is touch. So if the family feels like the patient's really not able to hear or speak or see, we can offer that they can still probably feel like their hand being held or like the feeling of like a blanket on top of them. So we can still offer that way to connect. And as I just said, touch is lost last. This is like really hard, and this is usually right before the patient dies. And I think we can offer sort of our standard spiritual care offers of like getting spiritual care involved. We can like help the family like acknowledge the loss, and we can think about sort of we're transitioning to a new relationship as the patient dies. Okay, this was my takeaway point for the end of this section. So I think just like briefly, as I was reading about this, the thing that struck me is, families have years and years and years of context of like the relationship they have with their loved one. And depending on the pattern of decline that the patient has had, they may have had years and years of knowing how to take care of this patient compared to you who might have only days or weeks. And it's a tremendous loss to lose some of the ways of caring for your loved one that you've been using for years. And I think our role is to really help the family express alternative ways to care for the person they love in the days prior to death. So I think this can really be of tremendous comfort to both the patient and the family. Okay, this is my last section, just a little bit more the nitty-gritty stuff you got to do after a patient dies. But before I move on, does anyone have any questions, comments on the previous two parts? So either the timeline of death or helping families cope. All right, seems like no burning questions. You can put them in the chat and I'm happy to circle back around if people have things they're typing out. Okie doke. So this is like the nitty gritty stuff. Probably a lot of us have practiced this. So the patient dies, you get a page or like an epic message, or they flag you down in the hall to let you know that your patient has passed away. I think everyone's probably practiced this, but just to review, maybe particularly for like interns who haven't had the chance to do this yet. So if the family is at bedside, if you don't know the situation, you want to like try to figure out a little bit what's going on. If you do know the situation, you can go in and talk to the family directly. You want to introduce yourself as like Dr. So-and-so on X team. You perform the death exam, which we'll review. You inform the family and the RN of the time of death. This is like a really important number that shows up in all sorts of paperwork. You offer autopsy services if the family is, you offer autopsy services, which the family can have if they're interested. You offer condolences, and you call the ME if needed. The family is not at bedside. You still should go to bedside first, do the death exam, declare the time of death, share it with the RN. You call the family to inform. You tell them that it's not an emergency. You know, it's that you do the call, you offer condolences. It's not an emergency for them to get there directly. If they're like, do I need to like speed in or like leave my child at home? It's not an emergency. The person has already died. You tell them who to ask for when they arrive, which doesn't need to be you if you're like going off, but it could be you. It could be the bedside nurse who's like, I'm going to be here till 7, or it could be the team that's responsible. So for example, if you're in the medical ICU and you're post-call and you're about to leave, you can still have them ask for MICU team A or MICU team B, and someone from the team can come and talk to the family when they arrive. And then again, you need to call the medical examiner if needed. Okay, I think this is the final question. I'm sorry, it feels like there are a lot of questions as we go through here. I like writing questions. All right, maybe people can commit to an answer and then we can wrap things up.
Sorry, I lost the poll. Let me look for it.
Oh, that's okay. If we totally lost it too, I can just tell people the answer. It can just be a freebie for the last one. But you got to mentally commit to something. All right, so we got a good split between A and B with very few people saying D. Regarding D, I regret to tell you that you have to fill out the death certificate. You can't make your attending do it. That's not like a rule, but I like the spirit. You can always try it on a new attending and see if they'll do it for you. Between A and B, we're going to briefly review some broad categories for like which deaths are reportable. And briefly, A is correct. This death is reportable because the patient had been transferred from King County Jail. And B, this death certificate, the underlying cause of death, I totally agree with, cirrhosis due to hepatitis C, but I'm going to briefly review death certificates. It was done in great depths by James Wachowski in Academic Half Day. But like one of my takeaways was like, you're not supposed to put cardiopulmonary arrest as like the underlying cause of death because it's not specific or helpful. So A is correct. Cause of death. So really quickly, summarized from what I saved from James Wachowski's academic half day. I thought it was really interesting, and the interns never got to see his great academic half day. Maybe he'll come back as a guest speaker. So your goal is to list a chain of events starting at the preliminary cause of death and going backwards to the underlying cause of death. So one of the examples he included in his academic half day was someone who died of a pulmonary embolism due to a COPD exacerbation. You're not supposed to list cardiac arrest, respiratory failure, or brain death as the preliminary cause of death, because like fundamentally everybody dies of one of those. So like doesn't help anyone with like knowing why the patient died or with any of our statistics. You want to be specific when possible. And if you don't know, or you're like, what the heck was actually even happening? I'm like cross-covering. You can reflect some uncertainty with likely or probable as qualifiers. So for our patient, I would say prelim cause of death for Ralph, upper GI bleed. I didn't share this with you, so you couldn't have said this, but prelim cause of death 2, variceal bleed from esophageal varices, and then underlying cause of death, cirrhosis due to hepatitis C. And then again, I didn't give you this information, but for example, significant comorbidities contributing to death could be AFib on anticoagulation and malnutrition. This is an example of how you could correctly fill out the death certificate for Ralph. And of note, the prelim cause of death is not cardiopulmonary arrest or respiratory arrest or cardiac arrest. And then briefly, a list of reportable deaths from James Wachowski. So long list, but I think like briefly, my summary is if you're ever confused, you can always call the ME. Big things to know is if someone was transferred from jail, prison, or another non-medical institution, so like notably not a SNF, it's a reportable death. If they died kind of peripartum, it's a reportable death. If they died and you just like don't know what the heck happened, it's a reportable death. I feel like this happens sometimes in the MICU where like maybe this person overdosed or like maybe they had a heart attack. Like I don't really know what's happening. Then it's a reportable death. If it's the result of an injury, it's a reportable death. So I feel like at Harborview this is also relevant, where someone's been here for like 400 days and you're like, why were they originally here? And they were originally transferred for like a fall causing a femur fracture. That's a reportable death because like it was a traumatic injury that set in motion the whole chain of events leading to their death. So that was very fast. James did a wonderful job explaining all of this over 45 minutes, and I just talked about it for 45 seconds. So just a little reminder about reportable deaths and cause of death. Okie doke, and this is my last slide. I want everyone to break. So briefly, our most important responsibilities after the patient dies include the death exam, notifying the family, whether in person or via phone, filling out the death certificate, which sadly should be done by us, and you can't really make your attending do it, and notifying the medical examiner if necessary. There are a lot of things that make it necessary. If you're ever confused or in doubt, the people are very nice, and you can always call them day or night, and they will tell you that your death is reportable or not reportable and give you a number to include in your note. And I want us to get to break on time, but I will look at the chat and answer any questions, but no one should feel obligated to keep listening. Oh, thanks for including that, Rima.
Thank you so much, Sophie. This is high yield and not something that we often get formal teaching about, so I really appreciate it. I think maybe we can come back at 9:54 or so, and we can get Gina to teach us about over-the-counter medications. Gina, I'm going to
Sophie,
run.
this
Sorry,
was
go ahead.
awesome.
Oh, thanks. I really enjoyed getting to learn more about this.
The
Great.
ultimate,
Yeah, that was like what I was referring to while I was writing this presentation for the end of this.
The ultimate academic half-day talk is one that something you want to learn more about, so you make an academic half-day talk about it. Gina, I'm just going to run to the bathroom quickly, but we can get your slides pulled up after, or John can help you out.
Sophie, what I admire is that something that feels so hard and really tough, no matter how many times you do it, that you broke it down into very, very concrete and very easily some tips that I'm going to definitely use in terms of some language and some scripts that everyone can use. So I very much appreciate that.
Oh, thanks. Yeah, I think it is a really overwhelming topic, and I had good teaching on it from other people, but still had questions. And I felt like the teaching I'd gotten was really empowering. So I wanted to share it with the folks. Yeah. And again, thanks for saying you like the photos. They're all from Wilma Jensen, if you want to look up more of them. I think she did a great job.
Yeah, they're gorgeous. They really are. Gina, do you want to try to see how your slides look?
Can you hear me okay, John?
I totally can.
Cool.
Are you in a public space or is that your home?
No, it's my home, but my internet might be on the fritz. We'll see.
Mm-hmm.
You guys just let me know if that happens.
Yeah, a good trick, and you probably already know this, if you're finding that you're choppy, turning off your own camera can shift the bandwidth to your voice, and oftentimes is an easy way to fix that, at least temporarily.
Okay, good to know.
Hey, John, while we're in break, can I share a funny story about that?
Please.
During the lockdown, I was doing some teaching on Zoom for younger medical students, and I was at home at my parents' place, and our internet sucks. And it kept cutting me out, and I did not know that trick. So every time I got kicked off Zoom, I was getting increasingly frustrated while trying to teach about a topic that I love, HIV medicine. And eventually somebody suggested that I call in using my phone so that even if my video goes, I can continue with the audio part. And I was going along for a good like 15 minutes, and then the computer Zoom cut out again, and I let out this like frustrated howl, forgetting that I was connected by audio to my phone, and everyone was really quiet. Eventually someone was like, "Are you okay?" And I was like, "Oh shoot." And then for no reason whatsoever, I think the attending who was present decided to lead the entire group in some deep breathing exercises at the end of my talk. And I was like, "I'm okay. I swear I'm okay."
We're going to use this as an opportunity to talk about deep breathing. Yeah, good,
So
good.
nice.
That attending was probably like, oh, I need to do something.
Tensions
She's
are high.
losing it. Her head's exploding.
I will say, well, I was going to say, Rima, I used that phone trick too during interviewing for residency. I was interviewing in a house with 5 other people also interviewing.
Oh gosh.
So it was a disaster.
Yeah. I have like 4 different kinds of input in my computer. I've got like this headset, which is probably the most reliable, and I also have like a microphone and all that sort of stuff. And then it's oftentimes clicking on, what's open and all that sort of stuff. Yeah, a profane proclamation. That's what I thought you were going with. I thought that's where you were going. Yeah.
Quick question, John. Do you see presenter mode, or do you see just the slides?
No, I just see the slide. Do you want to advance 1 or 2 and just make sure that it moves okay? Yeah, it looks perfect.
Cool.
Do you have video at all or anything like that, or audio?